Hi, my name is Caitlin Wilson. I'm a PhD student at the University of Leeds, funded by the NHR Yorkshire and Humber Patient Safety Translational Research Centre. Today, I'm presenting on developing an initial programme theory of pre-hospital feedback in an ambulance service setting, a mixed method study. This project is co-authored by my PhD supervisors, Dr. Gillian James, Professor Rebecca Lawton, and Dr. Jonathan Ben. A little bit of background about feedback in general. So one aspect of the feedback literature is audit and feedback. And we know from systematic reviews that audit and feedback can improve patient care and patient safety by enhancing clinical performance. A recently developed associated theory is clinical performance feedback intervention theory by Benjamin Brown. Feedback is also mentioned in occupational health psychology, where it is said that feedback can increase staff engagement. A related theory is the Theory and Techniques tool within the Human Behaviour Change Project, where mechanisms of action from different behaviour change techniques are identified. Lastly, feedback plays a big role in medical education, and it is thought that feedback promotes learning and increases motivation. Situated within that is a specific type of feedback called patient outcome feedback, and a recent publication in BMJ Quality and Safety by Sifra et al. Talked about how providing feedback on patient outcomes to clinicians could improve patient care. But we're specifically talking about the clinical context of the ambulance service, so I briefly want to illustrate why I've chosen this context, apart from the fact that I'm a paramedic myself. So traditionally, pre-hospital care has involved rapidly transporting patients to the nearest emergency department in the UK and internationally. But nowadays, paramedics and emergency medical technicians routinely assess and treat patients at home, refer them via alternative community pathways, and bypass local hospitals in favour of superior treatment in specialised centres. What this means is that emergency ambulance staff are spending much more time with patients and making much more in-depth and critical decisions. They're developing something called clinical curiosity, where they want to know whether the assessment and the treatment that they're providing is correct and what has happened to their patients subsequently. There's also an emphasis on staff mental health. Ambulance staff have low levels of staff engagement and well-being, and a systematic review by Petrie et al. Found that incidents of PTSD, depression, and anxiety are much higher than in the general population. So we're proposing that enhancing pre-hospital feedback may benefit clinical decision-making by facilitating learning and improve staff mental health by providing an element of closure. My PhD includes multiple projects. I've completed a systematic review and published an interview study. The study I'm presenting today is part of the review of current practice. My final study, study 4, is a diary study which is currently collecting data across all ambulance services in the UK. And I've also been fortunate enough to get extra pots of funding to undertake a Spark Award with the NHR, and also funding from the Yorkshire and Humber Patient Safety Translational Research Centre to co-design a best practice guide of pre-hospital feedback. So this study, the review of current practice. So pre-hospital feedback is increasingly receiving attention from clinicians, managers, and researchers, but there is a gap. I've already talked about how there's evidence from systematic reviews for the effectiveness of feedback in changing professional behaviour and improving clinical performance across a range of healthcare settings, but these systematic reviews haven't included the pre-hospital setting. Without a firm evidence base, development in practice relies on case studies and anecdotal reports of isolated initiatives with no clear evaluative framework. So the aim of this study was to understand how UK ambulance services are currently meeting the challenge of providing pre-hospital feedback, and to generate an initial explanatory programme theory to capture the implicit mechanisms by which feedback results in desirable outcomes. The design. So this was a realist evaluation consisting of 2 work packages. Work package 2 was a cross-sectional survey of existing and historical pre-hospital feedback initiatives in the UK. And work package 1 was qualitative case studies, each with 4 to 5 semi-structured interviews with initiative leads and ambulance staff. We also are undertaking documentary analysis and analysis of routinely collected data as part of these initiatives. Now, what is a realist evaluation? So it's a form of theory-driven evaluation that's method neutral. It seeks to answer the question, what works in which circumstances and for whom, rather than merely, does it work? It aims to identify the underlying generative mechanisms that explain how the outcomes were caused and the influence of context. We thought this study design would best address our study aim. So work package 2, the survey. This was a national survey that used purposive and snowball sampling. It was advertised on social media and sent to pre-hospital feedback initiative leads identified through grey literature and networking. In addition, 8 NHS ambulance trusts formally supported this study and identified further initiatives. The problem we had when we tried to set up this study is that it sounds like a service evaluation, but because it was coupled with the other work package and thereby part of the realist evaluation, it was formal research and we did apply for all the relevant governance and approvals. Let me share some of these results. So we had 41 unique responses from this survey that was live at the end of 2021. Of these feedback initiatives, 27 are currently active, and we had responses from 10 out of 13 UK NHS ambulance trusts. Predominantly, they were individual patient outcome feedback provided to individual frontline ambulance staff using email format, triggered by a request for feedback, which we call a pull initiative. Responses to our survey were that there were problems with implementation and sustainability, and we are exploring these further in the next step. Which are the case studies? These case studies were purposely sampled from the survey responses using a sampling framework stratified by feedback type and context. Each case involved 4 to 5 semi-structured qualitative interviews and documentary analysis, and I should declare data collection is still ongoing for this. But the focus of today is on developing an initial program theory. And first off, what does that even mean? So an initial program theory is part of the realist evaluation idea. So it shows us how and why an intervention works and under what circumstances. It's continuously refined throughout the study. It's essentially the researcher's best guess as to how this intervention works. It should be specific enough to generate particular propositions to test and general enough to apply across different situations. And to build an initial program theory, you can use primary data, previous studies, studies in other contexts, or your own experiences. We've used a combination of all of those, and I'm going to talk through about how I did that. So firstly, we started out with this context mechanism outcome configuration from Dawkin et al. So this is a key part to program theories and realist evaluation. Essentially, within a specific context, a mechanism is triggered and that causes an outcome. And Dawkin et al. Proposed that mechanisms should be split into resources and reasoning, resources being kind of the active key ingredient of the intervention, which is situated within a specific context, which then triggers a response from the actor or from the individual and leads to an outcome. So I then interpreted it as, what does that mean for my study? So resources, let's start there. What are the main characteristics of the type of feedback being provided? Context. I thought this would be about the barriers and facilitators to implementing pre-hospital feedback. Reasoning. What are the moderators and mediators governing the implementation and perceived effectiveness of pre-hospital feedback interventions? And then outcome. This was probably the easiest one. What are the perceived effects of pre-hospital feedback intervention, and how is pre-hospital feedback used and with what impact? So I've already said our initial program theory was developed using a range of data. We used the survey data, we used findings from our systematic review, and findings from our exploratory interview study that we had already conducted. but it was also informed by existing theories on audit and feedback and broader behaviour change and implementation science frameworks, several of which I've already mentioned. So there was CP-FIT, the clinical performance feedback intervention theory that's refined for healthcare in general, but not for pre-hospital care. And then the theoretical domains framework situated within kind of the behaviour change theory. And lastly, the implementation outcomes evaluation framework by Proctor, which is very much situated in implementation science and wasn't represented in any of the other theories. So I had CP-FIT, I had the theoretical domains framework, and I had Proctor's implementation outcomes framework. I then also had the interview study, and within the paper that we published on that, we actually generated a logic model. And then I had my systematic review, which we had, as part of that, we had used the theoretical domains framework to analyze some of these key ingredients of feedback mechanisms. And then I wanted to develop an initial program theory with not much of an idea of how to do that. So I used our initial interview study that I already had. I already had a logic model, and I already had an idea of this context mechanisms outcomes. So I mapped them onto the context mechanisms outcomes framework. I went through each of the theories that I had, and I started with CP-FIT because that was the most recent and closest theory relating to what I needed. So I looked at resources, feedback characteristics such as display, delivery, data collection and analysis, and goal. And then later, using Proctor et al.'s outcome framework, I added implementation characteristics such as adaptability, training and support, observability, and cost and ownership. They're situated within a specific context, and our interview study was really useful here to add things like feedback-seeking behaviour for the healthcare professional characteristics, which are not reflected in CP-FIT. There's also organisational characteristics such as resources, competing priorities, leadership support, champions, teamwork, intra and extra organisational networks, and workflow fit. So these specific resources within a specific context trigger reasoning, they trigger reactions in individuals. So my interpretation was that these were psychosocial kind of responses from individual, such as knowledge, skills, professional role, beliefs about capabilities and consequences, reinforcement, intentions, goals, decision-making processes, environmental context, social influences, and emotion. And then we come to outcomes. And again, this was useful from the interview study and the systematic review, but also CP-FIT and Proctor. Proctor in particular made it clear that first we have implementation outcomes, acceptability, adoption, appropriateness, feasibility, fidelity, penetration, and sustainability. And they could then trigger staff outcomes such as behaviour change, job satisfaction, and staff mental health, which again could lead to service outcomes such as organisational and team behaviour change, clinical performance improvement, team climate, improved patient safety, and improved service quality. So this was the logic model for our program theory, but actually a program theory is summarised in if, then, because statements. Examples of our program theory are: if pre-hospital feedback is provided with short lag time, electronically, and contains patient outcomes to ambulance staff who have a positive feedback attitude and employ feedback-seeking behaviour, then it is likely to lead to behaviour change, increased job satisfaction, and better staff mental health, because it will add to knowledge, beliefs about capabilities, consequences, decision-making processes, and address emotions. If pre-hospital feedback is implemented with observability, minimal cost, and a sense of ownership within an organisation that has suitable resources, champions, and utilise intra and extra organisational networks to ensure workflow fit, then it is likely to be accepted, adopted, and be sustainable. So as I've already said, this is only an initial program theory. So thank you for listening. And if you have any questions or comments on this presentation, please contact me, have a look at my PhD publications or my general PhD overview using the links in the QR codes. I hope you enjoy the rest of HSR UK 2022, and thanks again for listening.